Topic for today is resistant hypertension. Now, I will start with case studies. The first case, I think our talks, we are going to make it more of practical orientation so that it will help you in your clinical practice. Now, this is a 54-year-old obese gentleman with a BMI of 33. He's on 3 drug regimens: lisinopril, amlodipine, hydrochlorothiazide. And his BP measured in the clinic was 155 by 95. Now, despite 3 drugs, his BP is still on the higher side. So it is very important to take a proper history of the patient to assess whether he's taking his medicines on time or not, whether he's taking any other medicines which can have drug interaction and which can impede with the dose of the medicines and the level of medicine in circulation. So once you find that a patient has been started medications and you find that the BP continues to remain high, then we have to dig deeper into finding out the issues and how we can overcome the problems that this patient faces. Now, on taking a proper history of this patient, we found that he had missed midday doses. So the afternoon dose of his medicine he would skip. And hydrochlorothiazide, being a short-acting diuretic, it is less effective than chlorothiazide. Plus, he also had an element which is called as white coat hypertension. In fact, almost in 20% of the patients who come to a clinic, they have an element of anxiety. And these can cause an elevation in the blood pressure by almost 15 to 20 millimeters. So in addition to skipping his mid-afternoon dose, he also had an element of white coat hypertension. Now, how did we handle this patient? We did his ambulatory BP monitoring and confirmed that he had white coat hypertension. We simplified his regimen with combined meals. So instead of giving him 3 times a day, we combined it with the combination of drugs. So he would take 1 in the morning and 1 at night and simplify the process of taking his medicines. Plus, we advised him a diet program, especially the DASH diet, which I will elaborate a little more in details. We also advised him a walking program so that he does a regular exercise and reduces weight. The outcome of this patient was, as soon as we advised him, the lifestyle modification, the diet, and also confirmed that he had white coat hypertension, we altered the regimen of his drug, and subsequently the outcome was his BP over the next 6 weeks with proper dosing and adherence came down to 130 by 80. Okay, so much is the importance of taking a proper history and ensuring that the patient takes his medicines on time. Let me go to the second case. When to refer and follow up. This patient came, 67-year-old woman with a 15-year hypertension on 5 drugs. Can you imagine this patient has been taking 5 drugs? And her BP is 160 by 90. And she reports snoring and fatigue at night. A proper history of this patient revealed that her potassium was 3, indicating hypokalemia. On a physical examination, she had abdominal bruit, elevated aldosterone-renin ratio, and a CT of the abdomen revealed that she had adenoma of the adrenals. She had moderate obstructive sleep apnea syndrome. How did we manage this patient? On realizing that she had a tumor of the adrenal gland, we recommended that she should be surgically operated. A left adrenalectomy was done for primary aldosteronism, and for her obstructive sleep apnea, we recommended a CPAP. Medications following the surgery reduced significantly. So in this patient, we had a tumor which was causing hyperaldosteronism, and a surgical resection resulted in the BP coming down to normal. So at the end of 3 months, she was only on 2 drugs with a BP of 130 by 80. Ongoing monitoring of electrolytes and renal function was normal. So when you have a patient who is on drugs and whose BP still remains elevated, then we should think beyond essential hypertension. We should think that there is some other cause other than the routine cause for hypertension. Take a proper history, evaluate this patient, and treat the secondary cause if required. Managing resistant hypertension and understanding a complex condition. Now, when do you call hypertension resistant? Resistant hypertension affects about 10 to 20% of treated hypertensive patients. It carries a significant higher cardiovascular risk than controlled hypertension. This presentation explores our definition, diagnosis, management strategies for this challenging condition. When do you call hypertension resistant? If the BP remains above the goal despite 3 or more antihypertensive classes, of which one should be a diuretic at optimal dose. If the BP still remains, if the BP is controlled only with 4 drugs, this also qualifies as resistant hypertension. It is important that we should rule out the possibility of white coat hypertension before we jump to a conclusion of resistant hypertension. It is important to control the blood pressure because high blood pressure can increase your chances of getting a stroke, myocardial infarction, heart failure, and sudden cardiac death. What is the prevalence of resistant hypertension? 10 to 20% of the patients treated for hypertension have resistant hypertension. 10.3 million US adults have they meet the criteria for resistant hypertension. And it results in a 50% increase of either stroke, MI, heart failure, and death. This is the importance of identifying resistant hypertension and treating it and controlling it when required. What are the risk factors for resistant hypertension? Elderly people, as your age advances, the possibility of developing resistant hypertension increases. That happens because of changes in the vascular tone and increase in the rigidity of the peripheral vascular tone. Obesity is an independent risk factor for resistant hypertension. If the average BMI is more than 10%, it varies between 10% of the normal range, then we call that obesity, and it needs to be treated on aggressive footing. Chronic kidney disease, renal impairment complicates blood pressure control. And this is one of the very important causes for causing resistant hypertension. Diabetes, higher prevalence in patients with African ancestry, and controlling diabetes is of utmost importance in the control and management of resistant hypertension. What are the other risk factors contributing to hypertension? Lifestyle factors. High intake of salt. I think the average intake of salt should be, normally it is about 5 grams per day. But in hypertensive patients, you need to reduce the intake and bring it down to about 2 grams per day. Obesity, as I mentioned earlier, is one of the independent risk factors for hypertension as well as developing myocardial infarction. Physical inactivity. I think this is a very important thing in today's era where we don't have open grounds. We are more indoor. We are all stuck to our cell phones. We are stuck to our computers. We are stuck to our TV. Where there's no physical activity, that can result in hypertension, which is resistant. High alcohol intake is another very important thing. I think what is recommended is alcohol should be taken in moderation. 1 to 2 pegs a day is permitted, but if you take more than 2 pegs, it can result in causing hypertension. Another very important thing, especially for general practitioners, is to understand the problem of drug interactions. It so happens that if we take our medicines and if we take other medicines along with it, it can interfere with the biolevels of the drug available in circulation and can result in hypertension. To name a few of the drugs which can result in resistance is non-steroidal anti-inflammatory drugs. Steroids is one of the very important thing. In fact, steroids are prescribed on a regular basis at the general practice level and should be given in a very controlled manner only if it is necessary. Estrogens or oral contraceptives is another important cause which can cause uncontrolled hypertension. And sympathomimetic drugs are one of the contributing factors. So these are only few of the mentioned drugs which can interact with the hypertensive drugs and cause hypertension. So a proper drug history of the patient is very important as to what drugs he's taking, whether he's taking any painkillers or he's on any steroids. Even simple inhalers like even simple inhalers which have steroid can be responsible for increasing the blood pressure. So it's very important. In fact, I had one of my colleagues who was a doctor who had come for some problem. He had gone to the ophthalmologist for slight inflammation for the glaucoma, treatment of glaucoma. And he was given some treatment which had a small dose of steroids in it. And that was adequate for him to develop hypertension. So some people are very sensitive, and drug interaction is one of the most important things, which is often neglected in understanding the cause of hypertension. We should also rule out correctable causes of hypertension. And among the correctable causes, primary aldosteronism, as I mentioned, the first case, second case that I presented, patient who had an adrenal adenoma. Post resection, the number of drugs this patient required came down significantly. Renal artery stenosis. In fact, yesterday we had a very interesting case. Patient presented with, he had undergone an angioplasty in the past, presented with retrosternal chest pain. We got his angiogram done. He had a left main ostial stenosis. But along with that, since he had hypertension, we also wanted to rule out renal artery stenosis. So we just took 2 check injections of renal artery and found the patient to be having bilateral renal artery stenosis, more than 90%. Now, this was a dilemma because this patient got hypertension and he also had a significant coronary disease. Now, which are the 2 things we need to treat first? But since the patient had hypertension, we thought that doing a renal angioplasty was a very simple procedure. So we thought we'll go ahead with a renal angioplasty and then take him off a bypass. But when we had a group discussion between cardiac surgeon and cardiologist, we came to a very informed decision that we will do the angioplasty of one renal artery, then send the patient for a bypass surgery, and post-bypass, before the patient is discharged, we will do the plasty of the second renal artery. The cardiac surgeon, in fact, gave us an insight that if we do the angioplasty, bilateral angioplasty of the renal artery, the patient may develop hypotension because of the renal angiotensin mechanism being very significant. The renal levels will be very high. And if you correct the obstruction of both the renal arteries, that there may be a certain hypotension in this patient, which could be deleterious to this patient. So there's pseudo-resistant hypertension. White coat hypertension is an example, classic example. Can everyone mute themselves, please? White coat hypertension, especially high blood pressure in the clinic, is one of the important factors for pseudo-hypertension. Improper measurements of technique, I think, is so important to measure the pressure in a lying down position, and even ensuring that the BP cuff is tied properly and the BP recording is done in a proper manner. Non-adherence to prescribed medications is one of the important factors which can result in resistant hypertension and inadequate medications treatment, one has to give optimal dose of medications to achieve the goal of controlling resistant hypertension. What is true resistant hypertension? Uncontrolled BP on 3 full dose of medication, including diuretics. Controlled BP only after taking more than 4 drugs to control the blood pressure. Confirmed with out-of-office measurements, that is, doing ambulatory BP monitoring, and verified medication adherence. Only if these factors are satisfied, it would indicate presence of true resistant hypertension. Clinical evaluation of patients with hypertension, we need to take a proper comprehensive history of all the dose, the timing, confirming to adherence, assess the dietary habits, exercise habits, symptoms of secondary causes, if any, should be ruled out. A thorough physical examination is very important. Check the BMI, do a fundoscopic examination to find out for signs of resistant hypertension, do a cardiac assessment. Cardiac assessment would involve doing an ECG of the patient, doing an echo if required. Pulse evaluation, listen for any physical auscultation of presence of a bruit on abdomen, assess for unequal pulsation in upper and lower extremity, unequal pulsation in both the upper extremity, assess for presence of edema or thyroid enlargement. What are the testing required for resistant hypertension? A routine ECG, urine analysis to rule out whether there are any kidney dysfunction. Electrolytes, as I said, hypokalemia is an indication of aldosteronism. Renal dysfunction should be evaluated, and especially it is not just a serum creatinine. It requires eGFR to be done to assess what is the GFR and reduction in the kidney function. eGFR is far more sensitive than just serum creatinine alone. Lipid levels, especially LDL cholesterol and LPA cholesterol, are very important. Doing a thyroid function evaluation is another very important. Ensure that accurate BP measurements with multiple readings are very important before we decide or label this patient as systemic resistant hypertension. Confirm true resistance, BP greater than goal with more than 3 drugs at maximum tolerated doses. Exclude pseudo-resistance. Secondary workup, screening for secondary causes if true resistant hypertension confirmed, and assess target organ damage. Evaluate the cardiac function, evaluate kidney function, and evaluate whether there are any eye complications. I cannot stress the importance of ambulatory home BP monitoring. It's a very important, very useful tool to assess whether patient has got white coat hypertension or whether the patient has hypertension. In fact, last month we had a patient. He had undergone a bypass surgery about 20 years ago, and he was on hypertensive treatment. Now, this gentleman he was 87 years old, and of course, he had lost a lot of weight, and he was on almost 3 drugs for his hypertension. And he came to us with the history of a fall. Now, when the first family physician had a look at him, he said that this gentleman had gone to pass urine, and therefore he had a vasovagal. So I said, okay, then in that case, we will wait and watch. But exactly 48 hours or 72 hours later, he had a second fall again. And this time he injured himself. So I asked him to come down to our clinic. And he came down to our clinic. He had a small gash. We had to do a CLW. And when he came to our clinic, his BP was 130/80. So I was a little worried about his BP being almost on the normal side. And he was on 3 drug regimen. So I subjected him to an ambulatory BP monitoring. And to my utter surprise, his BP at night would come down to almost 100 by 7 days. We realized that his requirement for antihypertensive drugs had come down. And therefore, ambulatory BP monitoring gave us a clue that probably he must be having postural hypertension at night. And subsequently, on getting up at night, when in an elderly age group, your reflexes are slower, and therefore he had postural drop in blood pressure and had a fall. All that we did was we simply reduced the dose, repeated an ambulatory BP monitoring a few days later, found that the BP was remaining constant. It was a constant 130/80 at night or day. Send him home. The patient is doing well, no problem thereafter. And in fact, now he's planning to leave for the US. So, such is the importance of ambulatory BP monitoring. It gives you a total recording for the next 24 to 48 hours and gives us an idea as to whether our drugs, how to regulate the drugs, what timing to give the medicines, what are the drug interactions, if you are giving a combination, how to properly combine the doses of medicines. And by and large, you need to simplify the intake of medicines so that drug dropout is not there. That is the importance of ambulatory BP monitoring. And especially, it gives you the nocturnal patterns where dipping of blood pressure at night can result in a postural hypertension and fall at night. We may have to then reduce the dose of medicine, which I did in this patient, and he benefited significantly. What are the key laboratory and imaging workup? Basic laboratory tests like electrolytes, creatinine, phospholipid, urine analysis for proteinuria, endocrine screening, plasma aldosterone, and renin to screen for primary aldosteronism, cardiac and renal imaging, echocardiogram, renal ultrasound or Doppler, adrenal CT if indicated. Additional testing includes ECG, sleep study if OSA is suspected, and other tests based on the clinical suspicion of the patient. Secondary causes of hypertension, basically renal artery stenosis, rule out aldosteronism, adrenal tumors, kidney problems, and aortoartery is one of the important causes which can cause hypertension. What are the management of patient with resistant hypertension? I think most important which we speak of is lifestyle modification strategies. Weight management, target BMI should be less than 25. Even 5 to 10% weight loss can markedly lower the blood pressure. In fact, right now I have a patient who was weighing 92 kgs and had a elevated blood pressure. I just simply put her on lifestyle modification drugs and modification in terms of reduction in weight. And in a matter of 1 year, she has lost 10 kgs and the blood pressure has now come down to normal. That is the importance of weight management. Diet forms an equally important part of not only weight control, but even controlling your diabetes and metabolic status of the body. Diet rich in fruits, vegetables, low-fat dairy, whole grains, and limit salt intake to 2.4 grams per day and reduce the intake of saturated fatty acids. Regular exercise, aerobic exercise with greater than 150 minutes per week. Include also resistance training, which if possible is very important. Alcohol, as I mentioned earlier, 1 to 2 packs, less than 2 drinks per day and less than 1 drink per day for women. Quit smoking. That is the most important thing. I think smoking will not be permitted at any point of time. Alcohol in moderation is okay. Regarding pharmacological treatment, optimize triple therapy. Renal RAS blockers, calcium channel blockers, and diuretics at maximum tolerated doses. If despite this, the BP is not controlled, add a fourth drug, usually a mineralocorticoid receptor antagonist, MRA, in the form of aldosterone, which all of you must have heard. If the BP is still not under control, then you use a combination of beta blockers or alpha blockers or vasodilators as needed. In fact, when we were medical students, we had certain drugs which are in fact not mentioned now, which are now outdated. Especially, to convince old drugs like which are centrally acting like hydrolazine is still found to be useful in patients with resistant hypertension. Adelphin is yet another drug which today is not even available on routine basis. Methyl dopa, alpha methyl dopa is another generation of drugs which is useful, especially in patients with having resistant hypertension and in pregnancy. Methyl dopa, calcium antagonist, and labetalol would be useful in patients with hypertension and pregnancy. But we have now newer generation of drugs which are useful in controlling hypertension. So these drugs belonging to the older generation are now outdated. I would like to emphasize on mineralocorticoid receptor antagonist. The mechanism, they block the aldosterone effect, prevent sodium retention vascular fibrosis, addressing a common pathway for resistant hypertension. Clinical evidence showed spironolactone often yields the greatest additional BP drop in patients with resistant hypertension. And the dosing should be 25 milligram night, start low, titrate every 4 weeks, and important to monitor the potassium and renal functions. Side effects is spironolactone can cause gynecomastia, and if that is a case, then use eplerenone if spironolactone is not tolerated. And adherence and medical reconciliation is very important. Confirm the medication list, simplify the regimens. Provide adherence aid like pill boxes, smartphones, reminders, family involvement, and a multidisciplinary approach involve the pharmacists and the nurses for education and adherence. So educating the patient on how to take, when to take the medicines, involving the family members to give the phones or utilizing smartphones and pill boxes, they form a major part of treating these patients and encouraging medication adherence. Now, if after the entire regimen of drugs, and there are newer treatment modalities which are available, and though initially these are now available for more than 10 years. Initially, they were used, but then results subsequently were not very favorable. And again, now of late, results have come in favor of doing these procedures. Renal denervation is a very simple thing. It's done in the cath lab, where we put in the denervation catheter in the renal artery, and we stun the receptors of the sympathetic receptors, thereby showing a benefit of about 5 to 10 millimeters drop in the blood pressure. This is especially used in truly refractory cases. And another technique is baroreceptor activation therapy, where we have implantable devices on the carotid sinus. It delivers chronic stimulation to dampen the sympathetic flow. The Rios trial showed a sustained BP reduction of a mean of 35 by 16. Newer Barostim Neo demonstrates a good efficacy. However, in our country, this therapy is still not available. Maybe it will be available in near future. Very important to control resistant hypertension because there is a 50% increase in complications. 50% higher risk of stroke, of both ischemic and hemorrhagic stroke compared to controlled hypertension. Accelerated coronary disease, left ventricular hypertrophy, heart failure and arrhythmias, and renal failure, progression to CKD, end-stage renal disease with proteinuria from hypertension, and nephrosclerosis. So it is very important. Even ophthalmic complications can occur. You can have retinal detachment, hemorrhage in the retina, which can result in visual disturbances, including blindness. So I think I conclude this topic on resistant hypertension with a very simple talk that take a proper history, take a history of the medication of the patient, do a proper examination of the patient, and after you have proved that this patient has resistant hypertension, manage the patient, involve the family in the treatment of the patient, like renal denervation and bad technique. Okay, I think with that, I conclude my talk on resistant hypertension. We will meet again on the last Saturday of next month. We'll keep you posted about what is the topic. And thank you very much for attending this clinical session on resistant hypertension. Thank you so much.